Morning, everyone. I think before we start, I would like to ask a few questions. The first one is, who of you operates on adolescent idiopathic scoliosis? Okay, those who operate, who of those do operate only posterior? Only anterior? And both? Interesting. Yeah, still the majority is doing both. And I think the main reason is that there's no evidence. And I could stop here, but I tried to tell you what I've learned. Of course, at first we have to define what we are looking for and what are the aims of what we are doing, and that is to prevent progression, to stabilize the spine, to achieve correction, to maintain or correct balance, to maintain mobility, and of course all what we are doing should be safe. And I think everyone would agree on are the first two things, that anterior and posterior surgery is able to prevent progression and to stabilize the spine in the vast majority of cases. But concerning correction, balance, saving of segments and safety, there's no absolute truth. When anterior surgery arrived, we were all very excited because it looked like we get better coronal correction, we get better axial correction, we could better correct the thoracic hypokyphosis, and we could save segments. And therefore at that time we thought, do we need posterior surgery at all? But of course times have changed, because anterior surgery from that time is not the same anymore, because we went from soft rods to double rods and hard double and single rods, and also posterior surgery is not anymore the same what it was during the Harrington area. And therefore, if we discuss this, of course, and always if we judge this, we also have to look very carefully, is this a result of the approach, or is this a result of a modern instrumentation technique? As I said, the evidence is weak. There are no RTCs. There are mainly cohort studies, prospective case series, registry-based studies with their own problems, and retrospective case series. And this is a kind of classic, because at least to my knowledge, this was the first attempt really to compare these two techniques. And as you see from this list, there are very prominent people involved in that study, and that was prospective multi-center study, not randomized, minimum 2-year follow-up, and they had 78 patients in the anterior group and 100 patients in the posterior group. And the anterior, this Harms-Moss construct, was a flexible threaded rod, and posteriorly there were double rod constructs of that generation, CD or TSRH. And those are the results. In coronal correction, there was no difference. Correction of hypokyphosis in the thoracic curves was much more effective with the anterior, but in the anterior you had also a lot of hyperkyphosis, and this, what we know now, of course, was a result of the fact that this rod was soft, and also they had quite a lot of rod breakages. In balance, there was not really a difference, although it looks a little bit that the posterior cases were a little worse. And about saving levels, the assessment of this is absolutely difficult, because most people do not agree in posterior surgery how many levels they would fuse. And if you have no absolute standard for posterior, then it's difficult to compare to anterior. And therefore you see also in this paper, according to the one reviewer, they saved 2.4 levels, and according to the other reviewer, they saved 1.1 levels. That means their conclusion more or less was that coronal correction is equal, balance is equal, and they were able to save lumbar levels. Concerning complications, there was nothing really severe, but in the anterior group they had quite a lot of rod breakages related to the soft rod. But I think this is the problem we have with almost all studies. all the changes we are measuring and comparing, we cannot find out whether this has anything to do with outcome of patients, because in many studies this is not measured. Okay, saving levels was very popular earlier. I think it's not so popular anymore, at least what I see in posterior surgery, that people do not care so much anymore about saving levels, and I see quite a lot of cases where I would not fuse the lumbar spine with posterior instrumentation, but others do. But I have to admit, I don't know what is the absolute truth. Okay, this was a paper by Cochrane, and they seem to show that the lower you go, the more back pain people do have, and this also was significant. That means one should save lumbar levels according to this paper. This is a later paper from Danielsson and Nakemson. This is only radiology, and in this paper there was no difference concerning radiologic degenerative changes between those who were fused until down to L3 as compared to those who were fused to L4 or L5. But we have to see, this is a 22-year-old follow-up, quite a long follow-up, but there was no difference radiological. And this is a little bit another part of the same study, where are the same operated patients. There are also brace patients involved and controls. And in this case, they stated that there was neither a correlation between the length of fusion or subjective back stiffness, nor between the length of fusion and limitation of sexual function. According to that, at that point of follow-up, it didn't seem to matter how long you fused. There's a paper from material which was patients operated on at our institution. This is 78 Harrington patients, mean follow-up 23 years. Low back pain very often was in 13 patients, and there was no difference whether they were fused to L2 or lower. And therefore also this would not support the idea that we have to save lumbar levels. This is another paper from us where we compared Harrington on CD. Of course, this is historical, therefore there's quite a difference in the mean follow-up. But the CD patients, there were 10 segments fused, in the Harrington 11 segments, but concerning low back pain and SRS score, there was no difference. Saving levels, of course, mainly we think about mobility and protecting the disc, but we should not forget that it has also another implication, and that is that we minimize the operative trauma and we save money for implants and operation time and so on and so on. And that is also a reason why we should think about whether it's necessary always to save long. Of course, these cases are not comparable. I put them only up because there's one problem we have, and that is the longest follow-up we have, that is something like 23, 24 years. These patients are still around 40 years old. And what I see is that the answer will come when these patients are 60 or 70. And I'm afraid no one of us knows who of those two patients will be happier at that time. Will this patient get fractures here, spontaneous fractures? They are mainly female, and they will get osteoporosis, or will this patient have more problems down here? We really don't know, and that's what we should also always bear in mind. We need really long-term follow-up. Okay, concerning curve correction, there are several papers comparing how much correction do I get. This is a paper from Bridwell. Posterior pedicle screw, all pedicle screw constructs, and anterior duorod construct, minimal follow-up of 2 years, and they were comparable preoperatively. And you see that with the posterior pedicle screw construct, they had a much higher coronal correction, and they had also less loss of correction. But again, nothing is said about the outcome and the importance of these correction for the outcome. Another patient, another paper from Feng. You have 22 patients with posterior pedicle screws. We have 24 with anterior instrumentation. Primary curves were comparable, primary and secondary. No difference in curve correction, neither primary or secondary curves, and they were fused a little shorter anteriorly, and again, nothing known about the outcome. The next paper, this is very interesting. This material comes from France, from two different hospitals. One is from Dubussy, and the other is another hospital. This is obviously CD instrumentation. There were curves between 45 and 65 degrees, all lengthy one. And this is an anterior open procedure with a special plate which was designed for anterior thoracic scoliosis correction. And they found that the correction in the anterior group was better. There was a significantly better rotation correction, and also the improvement of the rib hump in the thoracic curves was better in this paper. And they stated that anterior instrumentation provided better correction of vertebral axial rotation and correction of the rib hump. There's very little said in most of the papers about the rib hump, even if there was rotation was measured. And this is another paper on rotation. There are 4 groups, in fact. This is anterior, and then you have posterior difference. There's also kind of historical development. You have hooks, a hybrid with hooks, hybrid with wires, and then all pedicle screw constructs. And rotation correction was absolutely better in the anterior procedure. It was poor in the hybrids, and it was quite good also in the posterior with pedicle screws. And they state that compared to the use of hooks and wires, rotation is effectively corrected by either the anterior approach or posterior pedicle screw fixation. Another one from Ree, 4 groups: anterior thoracic, posterior thoracic, anterior thoracolumbar, and posterior thoracolumbar. This is about the sagittal profile, which has also now risen as a topic which has not been so much discussed in earlier cases. And you can see here that the proximal part of the spine above the instrumentation, this is posterior thoracic as compared to anterior thoracic, gets more kyphotic than in the posterior thoracic as compared to the anterior thoracic. And if you take all posterior operations as compared to all anterior operations, they state that in 52% of the posteriorly operated patient, there's an increase of kyphosis above the instrumentation as compared only to 10%. But on the other hand, the kind of conclusion is then difference was small. Properly performed, both approaches can result in acceptable sagittal profiles. And I think this is also one problem what we do have. We measure things, we compare them, then we get some statistical significance, but we have no idea what this significance means for the clinical outcome. And this is again about thoracic kyphosis, anterior thoracic, 135 patients, posterior hook constructs 132, and posterior hybrid constructs 86 patients. And after more than 2 years follow-up, thoracic kyphosis was most improved in the anterior thoracic as compared to the others. And the statement is that ASIF is the best method to restore thoracic kyphosis. But I would ask you, what does it mean to restore thoracic kyphosis? If I want to restore something, that means I want to bring it back to something what it has been or what it should be. But do we know what is the right thoracic kyphosis for a girl with idiopathic scoliosis? We don't know what. We believe if we get more kyphosis that would be in some way better, but we really don't know whether it matters. Pulmonary function, is another topic which has been brought up in connection with the comparison between anterior and posterior. And here you see this paper from TIS that there are patients, 85 patients out of a group of 101, that is 85% follow-up, which is really quite good. Minimum follow-up is 5 years. Primary curve, secondary curve. Correction percentage was same in both curves, but there is a decrease of the FEV1 from 76% to 69%, but the predicted FEV is equal. This is a statistically significant decrease. It is called mildly in the conclusion. We are not sure whether this is of clinical importance. I think I want to show this and then go a little bit further, not to take too much time. This is very interesting. This comes from Croatia, and they looked at patients operated on anteriorly with a primary thoracic curve of more than 70 degrees, and they divided in two groups. Group 1 was 70 to 100 degrees, and Group 2 was over 100 degrees. 60 Group 1, 31 in Group 2. Only a 6-month follow-up of the pulmonary function. They followed them for some time more, but it didn't happen anything after the 6 months. And interestingly, the percentage of correction was almost the same. But what's more interesting is the vital capacity in Group 1 was unchanged after 6 months. But the vital capacity in Group 2, the very severe curves, became better. And the same they showed also for the forced expiratory volume at 1 second. There was a significant improvement, and that may have to do with the fact that if you have really a severe curve, that the change in the shape of the thorax may be beneficial. And what they saw was that happened only in the group of more than 100 degrees of scoliosis before operation. Could you advance it? Yes. I think we could stop there. We could take this off because it does not add so much. This may be worth to cite in this connection. There are 5 groups: thoracoscopic, posterior with thoracoplasty, posterior only, open anterior with thoracoplasty. And they tried to find out, are there any predictors for the decrease in pulmonary function? And what they found that the variables explaining 40 to 51% of the changes in pulmonary function. The most important were the preoperative pulmonary function, that those patients who had a poor pulmonary function before the operation, that they also were those who had a decrease. And other factors which were related to that were anterior approach, increased surgical time, and thoracoplasty. And this is in many papers that thoracoplasty also seems to have an effect. But it's also found out that it's really the thoracotomy. If you do a thoracolumbotomy or thoracoabdominal approach, this does not affect the pulmonary function, despite the fact that we are taking the diaphragm down. Could you advance it? Yes, maybe finally. This is surprising because this is only posterior surgery. But anyway, we believe that if we look for 1 year, or they look at 6 months, or if we look for 1 year or 2 years, this is the Danielsson, Nachemson, Persson paper, and where they looked after 25 years, they found that in brace patients and in posterior surgery patients that the pulmonary function was improved. That may be that those patients we see now with a restricted function recover after a longer time, and they found also that smoking and curve size were no risk factors in this material. To conclude, this is of course not absolute because the evidence is really weak. But let's say that's how I read the literature, or what I'm feeling is that coronal correction with modern instrumentation, there is probably no difference if we know how to do it. Actual correction, it seems that the anterior still is a little bit better, although there are also papers showing that it's not so bad with the posterior with all pedicle screws, and we must look for more data in the future. Sagittal correction, there seem to be a little more problems with the posterior instrumentation, and I believe that's only why we try to correct too much. I think the sagittal profile problems are created by overcorrection of the coronal plane or the rotation. Saving segments, still anterior is a little bit shorter. I'm not sure about balance, and anterior may be a problem for pulmonary function, but the problem is we don't know how significant this is clinically. And that's the final statement. The evidence is weak, differences are marginal, and that's again what I said already earlier. If something is statistically significantly different, is it really clinical? No outcome data, no long-term data, and we need RTC. Thank you very much.